Good morning, everyone. Welcome to our second quarter Palmetto Vision Alliance meeting. Today is Thursday, May the 29th, 2025, and we are thrilled to have everybody with us this morning. We've got a couple more folks that are joining from the waiting room, but it is 9:03, and we have a very exciting presentation for you this morning, and we don't want to delay that. So we are going to go ahead and get started. Thank you again for joining us. We have with us Dr. John Cruz, who is the mastermind behind the Big Data Project. Specifically, he's going to be talking with us about the phase two report from that project for the state of South Carolina. That is the characteristics of working age people with blindness and vision loss. And we are delighted that Dr. Cruz is here. We thank VisionServe Alliance. Lee Nazahi is here as well. They are the national stewards of this project. And we have a couple of Palmetto Vision Alliance members, including ABVI, Lions Vision Services, and Commission for the Blinds, that have been involved in funding and advocating for this project here in South Carolina. So we're very excited about this data and this report. And Dr. Cruz, we very much look forward to learning more from you this morning about how this is impacting our state in the working age population and how we can use this report as an advocacy tool in our work. So without further ado, Dr. Cruz, we will turn it over to you.
Okay, thank you. Good morning, everybody. I appreciate the opportunity to share some of this information. It's really dear to me. Kind of the more you know, the more effective we can be. Just so you know, real quick, I worked for the Michigan Commission for the Blind a long time ago, back in the late 70s, and developed a program for older people with vision impairment in the early 80s through some state funding there. And I was able to give testimony to Congressman Royball's office, Select Committee on Aging back in the early 80s. That resulted in the first funding for the Title VII Part C. And then I worked for the Commission for the Blind about 15 years, and then spent the last 20 years of my career working at CDC, by and large doing research in vision and population health. And so this kind of reflects both my kind of clinical experience way back where I really got all my ideas, and the kind of more recent research that I've done at CDC. So this is a romp. I've got about 40 minutes with a 90-minute presentation. So I'm going to skip over a few things. But I would encourage a couple things. One is I'm going to present a lot of data to you. There's no test on this. I want you to look at the patterns and not the specific kinds of findings that I'm going to share. You can do that on your own time. And I want to be a resource to you. So if there's a time that if you want me to come back and do another presentation, talk more about the policy implications of this, I can do that. So I'm going to run through this real quick. So I think if you're doing strategic planning, there's kind of a couple of questions that we ask or should be asking. The first is, who are our customers? And the second is, what do they want? And so we can begin to answer the first question with some of the data that I'm going to present today. And we can begin to make inferences about the second. So what I think about is kind of our sources of information. And so if you work in this business for a long time, I've been in it for 50 years now, you just know a lot. You know a lot just because you've been around. You know a lot of people with vision impairment. You have friends, colleagues, associates, a lot of clients that you work with. So we just have that personal experience. We make inferences from that. If you're running an agency, you have a ton of administrative data that you collect. So you know kind of the average age of the people you're serving, the age range, whatever the data are that you collect. What the missing piece is what I call population-based data, and that is, what do we know about the population about people who are older, who are visually impaired at the population level. And that's not just the people who come to the agency, people we know, but it's everybody else. So each of these sources of data have a limitation. but they complement each other, and I think in a fairly useful way. So what I want to do today is to kind of focus on two things. One is to examine the characteristics, social, economic, and health characteristics of people aged 18 to 64 with and without vision impairment at the state population level. So it's South Carolina specific. And then we're going to drill down into people just with vision impairment. So it's kind of two questions that we're asking. The first one is, are there differences? Are there disparities in terms of social, economic, and health factors between people with and without vision impairment? And then the second question is, are there social, economic, and health disparities among people with vision impairment that's defined by their labor force participation? So that's going to be so it's kind of a higher level and then more granular level approach to this. So just real quick, the data set that we're using, because some people are going to ask when you're presenting these data, because you will be presenting them someplace. The source of the data is the Behavioral Risk Factor Surveillance System. I think it's still in place at CDC. Lots of changes have occurred at CDC. And the the BRFSS is administered by the states. It gets financial support from CDC for every state, and the protocol is established by CDC. So while the data are collected at the state level, the same procedure is used in every state. So all these data are collected in the same way, and they're comparable. The BRFSS samples 440,000 people annually. It's the world's largest and oldest telephone survey, and uses what's called a complex sampling frame. That is, they're not just asking the first 440,000 people who walk by a series of questions, but they really target people who are at higher risk. And then as a consequence of that, you have to weight the data once you get it. The purpose of the BRFSS is really to inform health policy. And so it really, by and large, measures things like health behaviors, including smoking, or health risks like obesity. So the findings, so we know smoking is going down. We know obesity is going up. So it provides state level data, regional data, and aggregated national data where we can make decisions. So, but fortunately, within the BRFSS, since 2013, there is a vision question. Prior to that, there was none. And the vision question, this is really important because when we're talking about all these data, what we're talking about is our case definition. And the question is, are you blind or do you have serious difficulty seeing even when wearing glasses? So when we're talking about any of these responses, any of these characteristics, we're talking about the people who give a positive response to that question. So it's not the best question, it's what we got. So but the part of the problem with the question is it's a binary response. So you're asking, are you blind? Do you have serious difficulty seeing even when wearing glasses? Yes or no. And so we don't have a scaled response, which might be more useful to us. There is no question in the BRFSS that asks about vision rehabilitation. So we just have what we have. So if we just look real quickly at overview in South Carolina, there are about 208,000 people ages 18 to 64 who give a positive response to that question. Are you blind? You have serious difficulty seeing, even with glasses. And another 2.7 million people, working age people, who do not have vision impairment. So it means the prevalence rate for vision impairment is about 7.1%, roughly about 7.1%. Now, just when you're interpreting this finding, there are a lot of people who might have refractive error. Doesn't mean they're all legally blind if we have criteria for eligibility. There may be a whole lot of people in that group who have refractive error, just don't have glasses at all, and give a positive response to that question. So we have to be very careful in interpreting that question. So what I want to do is select some variables from the BRFSS, and we'll drill down into that. So here's what I want you to think about. First level is I want to look at people with and without vision impairment, ages 18 to 64. So among people with blindness and low vision, 31% of people in South Carolina have less than a high school degree in that age group. compared to 11%. So out the gate, people with vision impairment are disadvantaged. About 9.9% of people with vision impairment have a college degree compared to 26%. So a huge disparity to begin with. Then if we look at income, this is household income. The percent of people reporting $35,000 or less in household income is 33% for people without vision impairment and 67%. All right. So in terms of just those two indicators, there's differences, there's disparities. So if you look at some health issues, about 15% of people with blindness and low vision report hearing impairment compared to 3% in the general population. 20% report diabetes compared to 9%. 7% compared to 2.5% report kidney disease. 43%, and I start to see some patterns in these, 43% report depression compared to 20% in the general population. 11% report stroke compared to 2.5%. Now, you know as much or more about this than I do. Diabetes and stroke might be the pathway to vision impairment. It might be part of that causal pathway. Depression might be a consequence of vision impairment. So there's an association here. We don't know the direction of that. Hearing impairment may or may not be. I mean, hearing impairment is not causing vision impairment. Vision impairment is not causing hearing impairment. But the difference is already. Then if we look at the general population, comparing people with and without vision impairment, 46% of people with vision impairment report fair or poor health compared to 15% of people without vision impairment. Now, and the question for self-reported health is just ask, how's your health? Is it excellent, very good, fair, or excellent, very good, good, fair, or poor? So almost half of the people in South Carolina, working age, these are not older people, half report fair or poor health. And then there are some disability measures in addition to vision impairment. And interpreting this, I'm almost say your guess is as good as mine. If you're informed from a clinical experience, I think we can interpret this in a kind of an important way. So 44% of people working age report difficulty walking or climbing stairs compared to 10%. 51% report difficulty with cognition. I'm going to talk about that a little bit more compared to 12%. And 35% report difficulty running errands compared to 6%. And the running errands question is kind of like the old IADLs, just a number of activities involved in that. Now, what I think is happening, I don't know. What the way I talk about this is this is kind of excess disability, and so my question is if people with vision impairment, 44% of them are reporting difficulty walking or climbing, is that an O&M issue? Is that an orthopedic issue? Is that a conditioning issue? It's a sum of all of that, but teasing out the causal pathway to that result it takes some thinking. All right, now so interpreting these findings again, I've already thrown a lot of data at you, but we've begun with people with and without vision impairment. We're going to talk a little bit more about that. Then we're going to look at within group variability. So we're going to look at the distribution by labor force participation, and we're going to look at health, chronic conditions, health-related quality of life, and disability measures. I think all of this certainly has clinical and practice implications, but it has big-time strategic and policy implications. And I tend to be, as I don't know, I'm 78 now, but I'm really interested in disability policy and how that gets translated into action. And we're in a very frustrating, irrational environment, and hopefully it will become more rational, probably not in the short term. Now, in the BRFSS, as opposed to the census data, there are 8 employment categories, and this is richer, in fact, than the BRFSS, than the census. And so I want to describe each of these very, very quickly. The BRFSS just asks for the respondent to identify what category they belong to, and they read these 8 categories. So it's employed for wages. Now, the question does not say full-time or part-time, just says employed for wages. Ask for self-employed. Again, we don't know if it's full-time, part-time. We don't know if the people happy with the work, unhappy with the work. If it's a great job, it's a lousy job, we don't know. Then there's a question about out of work less than a year. So somebody has worked, but now they're unemployed. And then fourth question is, are you out of work more than a year? So you can figure that out. So the first 4 questions really deal with people who are working or have worked. And so if you're looking at this from the point of view of vocational rehabilitation, there's implications for each of these. If you're looking at a broader lens of rehab, there's another way to interpret some of these. Then we also characterize the percent of people who are students, retirees. Now, we're looking for this purposes of this investigation, we're just looking at people ages 18 to 64. So we don't expect too many people who are retired, but think about the responses to this. It's kind of what I call social desirability response. So if you're 58 years old and you can't get a job and you're visually impaired, you might just say, I'm retired, rather than say, I can't get a job. That's more socially desirable. This category of homemaker, and then this one, unable to work. And frankly, before I did this work for Lee, I never really paid much attention to this category, but it's kind of gobsmacked, if that's the word, by the responses. Okay, let's see what we get. So this is overall in South Carolina. 30% of people with vision impairment say they're working for wages. We don't know, full-time, part-time, good job, bad job, compared to 60%. 8% are employed or self-employed compared to 10%. So probably within the confidence interval. 4.8% are unemployed less than a year compared to 3.3%. So probably within the confidence interval. 3.9% are out of work more than a year compared to 3.2%. So we're going to drill down into each of these groups, and try to better understand what the dynamic is within this. What I would suggest to you is that, again, for those of you who are seasoned, none of this is going to be a surprise. It's just I'm giving you some numbers for what you have already seen. About 3.3% of people are students compared to 6.7%. So this is concerning. Why is it that young people with vision impairment are half as likely to be students as people without vision impairment in South Carolina? The retirees, 6.3%, 5.3%. That's kind of within the same range. The same number of people are homemakers. Now, this is the one, 39% of people with vision impairment, working age, say they are unable to work compared to 8.2% in the general population. This is all other disabilities. These are people who have mobility, intellectual disabilities, injury-related disabilities. So we get 39% compared to 8.2%. So you can see this distribution. Frankly, I was not prepared to see these kinds of numbers. So maybe that's just who I am, but I was surprised by that. Interpreting this is kind of hard, but we'll drill it down into it. Okay, so just these patterns at the state level. We're not drilling down more, but the patterns show a very large proportion of people reporting unable to work. A lower proportion of young people in college in South Carolina compared to people without vision impairment. We're going to see a very high prevalence of poor health, depression, chronic conditions in each group, and then what I call excess disability. And then I want to talk a little bit from a policy point of view. This is a clinical point of view. This is both. It's kind of this bi-directional nature of the experience of blindness and low vision. I don't think we talk about that enough. I think it's such an important concept, so I want to drill into that. So here's what I want to get at, this bi-directional experience of blindness and low vision, is that there are upstream factors related to place, income, education, and health behaviors that have downstream effects. And those effects so you think about it. I'm in Georgia now. South Georgia is incredibly rural, very poor, very high prevalence of blacks. Virtually no resources. All the resources are in the Atlanta area. So if you live in South Georgia, that experience of growing up is going to be different. South Georgia is very poor. There are no good jobs to be had. Education levels in rural South Georgia are kind of not as desirable as one would like. And then if you look at kind of health behaviors, if you've got poverty, then trying to get a meal is a different kind of thing than we do. So if we go to Publix and we're getting strawberries and romaine lettuce and apples and fruits and vegetables, all that sort of thing. That's an expensive decision. So you have to have some wealth in order to do that. It might be cheaper. I'd say to go to McDonald's, but I don't think that's the case these days. But if you're poor, you just want something in your tummy. So you're not thinking so much about the quality of that food. So the downstream effects then of that is that you may have difficulty finding work, may not be work available, or the work may not be the quality that you want. There may be health effects of long-term, developing diabetes. If you go to South Georgia, I suspect the prevalence of diabetes is really high. If everybody has diabetes, then you can't think that's normative. Maybe problems with social mobility, and then there may be the development of chronic conditions. So what's important about this is that I think what it helps to do is to understand how each of us champion particular issues and contribute to this idea. And the broad term that's used is social determinants of health. That's really the kind of concept that we're getting at. So if you're working in the schools and trying to improve the school experience for people with vision impairment, that's an upstream factor that you're trying to manage. If you're working on transportation in the community, that's affecting the environment. So we're working in all these areas, but I think looking at the effects allows us to kind of orchestrate some of these activities a little bit more. So what I think is when we look at this experience of blindness and low vision, is there are opportunities to bend the curve. And we need to start thinking about what are those activities that begin to bend the curve. All right, so now what I want to do is drill down into these 8 employment categories and talk about some factors in each one of them. And I'm going to skip around a lot. So just bear with me because I want you to see the patterns and not the specific examples. So among people who are visually impaired, who are employed for wages, we don't know if it's a good job, bad job, full-time, not. 23% have less than a high school degree. 34%, 35% have a high school degree, and 24% are college graduates. Okay, so having a high school degree and a college degree is associated with employment. That's not a huge insight. But if you look at the people who are self-employed, 47% have less than a high school degree. I mean, this is 2025, isn't it? 27% have a high school degree. Only 3.1% have a college degree. Among people who are out of work less than a year, 65% have a high school degree, and 45% have been out of work more than a year. So we're already seeing another pattern within each of these groups. Among students, this is interesting. Remember, it's only 3.3% of people in South Carolina are students compared to 6.7% of people without vision impairment. 19.7% are still in high school. So South Carolina is reaching those kids. This is 18 and this is 18 and over. 34% have completed high school, and 6.8% are college graduates. So some people are being probably supported by VR to obtain graduate degrees. Um, let me jump to this unable to work group. 43% have less than a high school degree. 38% have a high school degree. So again, each of these categories is associated with differing levels of education. Now let's look at income, another kind of factor here. Now look at this. These are of the people who are working, 48% are making less than $35,000. So we don't know if it's full-time, part-time, but $35,000 is not a whole lot of money. Among people self-employed, 57% make less than $35,000. This is the household income, not just for the person. 87% of people out of work less than a year make less than 35,000, and 93% of people who are out of work more than a year are making less than $35,000. So there's a lot of poverty. These are means, obviously, for each of these. Students are doing pretty good, I think. And then if we look at people who are unable to work, 90% of people who report they're unable to work have less than $35,000. So again, so if you start thinking about this again from point of view, if you think about VR, well, one target for this would be people who are out of work. You want to get them back into work, and so there's room, hopefully, to recruit people who have had an experience in working. Students are going to get a job because we know people with a college degree are pretty successful. I would hope there might be some homemakers that could be drawn into VR. People who are unable to work have a lot of things going on. And again, if we use this social determinants of health model, we can begin to understand why we have this. Now, it might be, again, interpreting these questions. So if you think about, again, we don't know, but just think about this. If somebody calls up and they say, I'm from the government and I want to do this survey, and you're getting SSI or SSDI, and then they start asking you these questions, you're going to see you're unable to work. Likely, I would, assuming that somehow the BRFSS is connected to Social Security. It isn't at the moment, but there might be an incentive. So there may be a few people in this group unable to work that could work. All right, now let's look at just health and health behaviors within each of these groups. So of the people who are working, 33% say their health is miserable, is fair or poor. Among people self-employed, 40% say their health is fair or poor. Among people out of work more than a year, 71%. So if we're trying to get people back into work, and they say their health is fair or poor, health is a factor that we need to think about in terms of getting people back into work. Among students, 32%, would assume that this skews towards being younger people, but 31% say their health is fair or poor. Among people unable to work, 61% say their health is fair or poor. So let's look at some things that might contribute to that. Among people who are working, 26% say they're depressed. 26% say they're depressed. 16% of people self-employed say they're depressed. 52% of people out of work less than a year say they're depressed, and 43% of people out of work more than a year. So people who are working are doing pretty good in terms of depression. People who are out of work, so we already seen that people who are out of work less than a year or more than a year report poor overall health, and then they're depressed as well. So that maybe it's hard to get a job, hard to be turned down. You can kind of understand this. And then students, I'm really interested in this student group and the pattern that it surfaces. 40% of the students say they're depressed. And I worry about this for a number of reasons. Now let's look at diabetes. Among people with who are working, 6.2% say have diabetes compared to 14% of 15% of people self-employed. We don't have enough sample size to look at people who are out of work less than a year. But as we look at these various groups, diabetes tends to be higher among people who are outside the work environment. Then if we look at hearing, it varies as well. Among retirees, it's 39%. So mostly among men. So that's kind of age-related hearing impairment, but not too high among people who are working. All right. Now, in the report that I sent to you, we look at 12 chronic conditions, and I published several papers around these disparities. We look at stroke, heart disease, asthma, high cholesterol, any cancer, heart attack, COPD, kidney disease, and arthritis. In all cases, people with vision impairment are more likely to report these chronic conditions. So it's not, it's not just people have vision impairment. It's vision impairment in the context of a whole lot of other things that affect other factors. All right, now I want to focus on two health-related quality of life questions. There's a module within the BRFSS called health-related quality of life, where I looked at one of those. Would you say your general health is excellent, very good, fair, or poor? But then I want to look at two of these. Then I'm going to jump to some conclusions. The first question is, now thinking about your physical health, which includes physical illness, injury, for about how many days during the past 30 days was your physical health not good? And then there's a follow-up question that says, now thinking about your mental health, which includes stress, depression, problems with emotions. And we know people have reported a high level of depression. So this is kind of a question that reinforces that. For how many days during the past 30 days was your mental health not good? Now, in doing the analysis for this, what we look at is the percent. What I'm going to show you is the percent of people who report 14 or more days of mental health problems, or 14 or more days of physical health problems. So this is, so if we look at people who are employed for wages, 13% report poor physical health. 27% of people with their self-employed report poor health. And this pattern is pretty well established. 44% report of people reporting less, working out of work less than a year. I'm sorry, report poor physical health, and 31% of people more than a year. So is health is an issue. 12% of students report poor physical health. Now let's look at mental health. There's some striking examples. About a quarter of the people employed for wages report poor mental health. 14 or more days of poor mental health, not just occasional. 60% of people out of work less than a year report poor mental health, 14 or more days. And look at this, students. 74% of students report 14 or more days of poor mental health. And I just think about what this means. If you're a student and you're in a competitive environment and you're trying to memorize a lot of material, trying to read a lot of material, that's pretty demanding. And I don't think we often appreciate how difficult that is. Now, so let's jump to some disparities in disability measures. I'm just going to wrap this overview up. So the 6 disability questions in the BRFSS and the American Community Survey, same questions, different sampling frame. So the question is, do you have serious difficulty hearing? We've seen that. So it's serious, not any difficulty. Are you blind, or do you have serious difficulty seeing? That's our case definition. Do you have serious difficulty concentrating, remembering, or making decision? It's a cognition question. The idea is to capture people who have all sorts of cognitive limitations. So if you have Down syndrome, you have a positive response. If you had Alzheimer's disease, you have a positive response. So the question is designed to capture those kinds of things. Do you have serious difficulty walking or climbing stairs? Do you have any difficulty dressing or bathing and any difficulty doing errands? So note the first four questions have this caveat of serious in them. The last two questions kind of any difficulty. So let's look at this real quick. People are employed for wages, 14% report difficulty walking. Self-employed, 25% report difficulty walking. People out of work less than a year, 34%. People out of work more than a year, 76%. So it's excess disability. That's the term I'm going to use. So is this an O&M issue? Is this a orthopedic issue? Is this an injury issue? We don't know. But if these people are going to get in, for the first two groups, people who are employed for wages and self-employed, they're getting to work. They might hurt, but they're getting to work. For the people who are out of work, it's a more serious issue. Let's look at concentrating this cognition question. 30% report among people employed for wages, 35% among people self-employed. Let's look at the students. 82% report difficulty concentrating. So remember, that's concentrating, remembering, and making decisions. So if you're a student trying to memorize vast materials of information, being tested all the time, I can understand why that might be. So what I would kind of be asking, I think, with this response is I want to know more about the students and how they feel. Do they think they're being supported enough? Do they have the strategies to synthesize information? Do they, how they manage test taking and kind of the anxiety around that? So we see these patterns. So what does this overview tell us? Well, one, I think, is just the grit. You think about the people who are in all these circumstances, all these categories. People report all, multiple chronic conditions, and they still go to work. They still have a job. The other piece, I think, is that there's just this excess disability. So it's not vision impairment, but it's in vision impairment in the context of other kinds of disabling conditions. So it's not just hearing impairment and vision impairment, but it's hearing impairment, mobility impairment, hearing impairment, and cognitive impairment. And we need to think about how to address that. And the potential inferences are, how do we shape both clinical services and public policy to address that? So, how do we use these data? Well, one is, I think, it's data rich. It's pretty dense. Even our presentation today is dense compared to the report, but it informs strategic planning. It also, I think, drives policy development. So, and suggests, I think, ways to engage stakeholders. When I worked in the Michigan Commission for the Blind, I never thought about public health. I just thought that's where you got, free flu shots. But public health should own some of this. Federally qualified health centers where people get care should own this as well. I think it helps to redefine the outcomes. So one outcome that we don't talk enough about in vision rehab is improved health and quality of life. And so one way to improve health may be to view O&M as a mechanism for exercise and conditioning. And so if somebody's going to work 40 hours a week, they have to not only be able to get to work, but they have to have the stamina to work when they get there. Now, so we talked about this bidirectional thing. I think this is important. So the precursors are these upstream factors: place, education, income, social position. The consequences are the downstream factors that deal with educational success. More education you have, that predicts success in multiple realms. The stability of employment, and the development and prevention of chronic conditions, and just the development of wealth and health literacy. So we need to think about, is there an opportunity to bend this curve across all these factors? And how do we organize that? So there's a good bit of discussion around social determinants of health. And the guy who's kind of drove that thinking early on is a guy named Michael Marmot. And I I'm going to give you some share a publication that I suggest to him. So one thing that we already know, I don't have to tell you, is that the vision eye health system, vision rehabilitation, all that, is incredibly fragmented. Vision rehab, I think, is often it's just isolated. It's not linked to the eye care system. It's not recognized as a part of health promotion. Often is not viewed as having the same status as OTPT. So we're just kind of out there on our own. Some other things that contribute to that, again, don't have to tell you, there's no reimbursement or little reimbursement for vision rehabilitation services. OTs have billing codes, but vision rehab folks do not. Vision rehabilitation tends to get isolated from other health concerns. That is, we're just dealing with the vision impairment, but not in the context of all these other health conditions that we've identified today that you already know about. And I think it's, from a policy point of view, it's exceedingly hard, if just not flat impossible, for people with vision impairment or any disability to move into and out of work as health permits. You know, it's if you if you say, well, you know, I'm going to give up Social Security as SDI and I'm going to go out on my own, getting back in that queue is really difficult. It should be easy to do. So there was a guy named Hugh Taylor in Australia, and he's not trained as an ophthalmologist, but he's really interested in public health. And he developed this thing they call the leaky pipe, and so this is an Australian model, not a U.S. model. What he was saying was, you know, the patient comes in at one end of this leaky pipe, and Australia has kind of a different model where they'll see an optometrist first, and services are kind of rationed, so you get on a waiting list, gets to see an optometrist, and the optometrist refers to an ophthalmologist. You get on an ophthalmology waiting list. You get the ophthalmologist. The ophthalmologist may require surgery, and so you get on this thing. And so what so you've got this long, cumbersome process, kind of the sclerotic pipe, if you will, and people are dropping out of it all the time. And I saw that, and I was kind of, oh, that's pretty cool. How does this how does the U.S. model compare? And this is what I think it looks like. It's just this pile of fragmented elements, and sometimes we will we'll work with other partners. We'll start to try to create a system. So you might work with the aging community, you might work with federally qualified health centers, might work with public health. There are other partners that you will find, but there's no system, and either reimbursement or in terms of referral and so forth. So here's, I think, some ways how we might begin to make sense of some of this. The population of health with the population of people with vision impairment it's large, and it's getting bigger, no question about it. The experience of vision impairment is dimensional. We've kind of nailed that. But the experience is also dynamic. And so when we look at this profile, this is not a static experience. Left alone, it's likely to get worse. It's not going to get better on its own. It's going to get better because we, by and large, do something about it. And I think we have to communicate that more. If we can provide we're on a trajectory for poorer health, these other poor outcomes. And so if we can bend that curve, you don't have to solve the problem, just bend the curve. And I think we can show that. The other thing about this experience, and this is the reason we're in vision rehabilitation, is that the experience of blindness and low vision is malleable. We can do things about it. So we can design and implement interventions that bend the curve, improve health, employment outcome, and so forth. All right. Now, I'm going to wrap up real quick. The book, some things I suggest to you is Michael Marmot's book called Social Determinants of Health. There are tons of articles now on social determinants of health. It was until January. I don't know what the status is now, but it has just the concept has great cachet within public health, and within HHS. So we'll see how that goes, but just check that book out. And then I'm going to include a slide, and what I'll send you these slides and you can look at this yourself. But I think when you're looking at the findings in South Carolina, it's useful to say, well, how do we compare with other states? And so there's some kind of wiggle room around each of these factors. One I would be concerned about is this is interesting in Kentucky. So let's look at this real quick. 41% of people in Massachusetts are employed for wages, compared to 29% in Alabama, 30% in South Carolina. So Massachusetts really has done well, but only 2.6% of working age people are students. I mean, there's a university on every corner in Massachusetts. Kentucky has 6.6% in school. So that group's going to do well. If they can get out of college, they're going to do well. So there's a good bit of variability about that. So I would think, how could you improve getting people into this pipeline? And then the other factors are you can just see where you relate. So it's useful to compare not just within South Carolina and with people by employment status and people without vision impairment, but what's the difference regionally? And what you'll see is that all of these patterns have regional influences. South Carolina is a lot like North Carolina. Mississippi and Alabama are a lot alike. Washington and Oregon are a lot alike. So you got these kind of regional differences. So it's not just state specific. All right. The other thing I would suggest to you is the last project I did at CDC. It was an Institute of Medicine, a National Academies of Science and Engineering report called Making Eye Health a Population Health Imperative. There's a chapter on vision impairment in there. It's not gotten the traction I think it should in the vision rehab community. Okay, so that's it. Happy to answer any questions. I'm only 5 minutes over. I want to be a resource to you. This is very important to me. I think there's power in having the data and having practitioners and policymakers looking at these data and just asking, what's going on? Are these the patterns I expected? Are there things that we can do about this? Is this at the clinical level we want to do something about it? Is it at the policy level? Oh, my cat is now supervising my presentation. So if you want me to come back and we talk about this a little bit more, I'd be happy to do that. If you're writing a grant or a proposal, and I think you've got the information, but if you just want to pick my brain, always happy to do that. That's what I'm here for. And that's what I enjoy in retirement, is doing this kind of mentoring. Okay, thank you very much. Appreciate your time.
Thank you, Dr. Cruz. This has been very exciting, very insightful information, very sobering, certainly, in our fields of work to see a little bit more specifically where we are in South Carolina. So we really appreciate that. I will preface this with just saying, as far as Palmetto Vision Alliance is concerned, we're happy to keep the call going past 10 o'clock. We want to be respectful of y'all's time, since we said that the program was from 9 to 10, but I'm happy to keep things going beyond that if the group has time. So I'll just open it up to the floor if anybody has any questions for Dr. Cruz while he's here today, or wants to dig into anything that he shared with us today.
Wake up, wake up, wake up. I'm
I'll, I'll,
happy.
I'll
I mean,
start us
I
I'll
know
start
this
us
is
off.
provoking. This is a lot of information,
It is.
and
It
there
is.
is no wrong question. If this provokes you to think about something in a different way, you know, and if I haven't thought about it, then that's great, because that's learning for me. So I just, maybe it's just overwhelming. One of the things I think that's disturbing about this is not the way I want the world to be. These are not the findings I want. I would love to see some kind of parity and or a movement toward parity that, people are working good jobs, that they're in school, that they're successful in school, that they have good health. It suggests to me that a whole lot of systems have failed people with vision impairment. And the questions are, how do we begin to deconstruct these problems in a way that we can begin to solve them? So you don't want to just look at this and say, this is just so overwhelming, I can't do anything about it. What we want to say is, given the complexity of this, what can we begin to do? So is that to have a dialogue with the with public schools and say, you know, if we're not preparing people to go from high school to college, if we're not doing that, we're affecting their whole lives. And so what more can we do to support children and parents in those very delicate ages? And then what can we do if you think about these patterns of poor overall health, which I think is hugely concerning? People have to be healthy to work. There's a body of research called the healthy worker effect. And the idea is that if you're healthy, you're likely to get a job. But if you have a job, then you're going to be healthier because you've got money, you can eat better, you can exercise and conditioning. And so we need to think about what are these dynamics that create poorer health, and how can we alter those patterns?
Yeah, absolutely. Amy, I see you're off of mute. Did you have a question?
Yeah, so I was curious. From my understanding, the presentation was, based on this population of, can you not see, or do you have a very hard time seeing even with glasses? We work a little bit more on the preventative side, and I was curious if you had any just strong opinions about preventative work and what you would focus on as far as, well, there's kind of two categories I was playing around with in my head. Like, is the focus of where we reach people more important, or is the focus of which disease are we concentrating on that's more important? Because of course you have diseases like glaucoma that's irreversible, so we always want to get in early for that kind of thing. But then a lot of those the people living in with glaucoma, they're not oftentimes students. Usually they're a little bit of a older population. So kind of a two-part question, because then the other side of it is we are right now are reaching out mostly to free clinics, which we just adore working
Great.
with
Okay,
them.
super.
But maybe there's also an opportunity where we need to be reaching out more to colleges, which is not something we've done in the past, or even to temp to hire facilities that are helping people get temporary jobs, stuff like that. So kind of a two-part question, just wanting to
Yeah.
pick your brain a little
Well, I
bit.
know, I think that's a super question. Thank you for asking. Um, so just so you know, in retirement, one of the things I have done is to kind of taken my portfolio of research to Ohio State, and I've been working with them, I guess, for the last 8 years since I've been retired. And we just submitted an NEI grant that is addressing exactly what you're talking about, Amy. Um, and so the big issue is, and you think about this just in terms of a kind of public health model. The first stage is, how do you get, well, in fact, let me back up. Amy was not paid to do this. But since you asked, so this is what a public health model looks like. You got a problem and you want to do something about it, right? So,
Mm-hmm.
so what we've talked about is this is surveillance. And so just the numbers. And so in public health, surveillance is the foundation of public health. And so if you get the numbers wrong, if you overestimate the number and you dedicate resources, you're wasting resources. What by and large happens, I think, in vision impairments, we underestimate not only the numbers, and then, so we've talked about that, the number a little bit today. And then the second piece of that is to ask the question. So if people with vision impairment are not at all different from people without vision impairment, it's like, okay, problem solved. We don't have to worry about these other kinds of health issues. But what we've shown is disparities. So we have these disparities, and then as we look, whatever factor we're looking at, disparities surface. So it's not just this one disparity. It's not just people with vision impairment and hearing impairment. It's a constellation of disparities that we have identified. And then the next step in this model is, well, what are you going to do about it? Given this complexity, what are you going to do about it? And then you try to test models. And so you're doing that. You say, well, we want to reach people who are at high risk of vision impairment. We try various strategies and we figure out which ones work and we refine them. But the idea that once we figure out what's works, then we can implement that either at state level or national level or community level. So we're kind of right now, by and large, this presentation is here, but it should inform what we do about it. So what we just proposed to NEI, we submitted the proposal to NEI, and then NEI decided they weren't going to fund under that funding mechanism, and now we're resubmitting. So, but we're testing a hypothesis, like how do you improve access and utilization of eye care? That's really what we're trying to look at. And so some can be more passive. So you're doing educational things, with brochures and fairs and things like that, and just trying to improve health literacy, health awareness. Some communities, I think, are less likely to use eye care. I think Hispanic community is probably less likely to use eye care. I think it's a kind of a cultural thing or trust thing. And so how do you reach people in the Hispanic community who may have just refractive error, easy fix? So one question is, what are potential strategies? So one might be more passive, just trying to educate people. So you mentioned, the association of age and glaucoma. So people need to know that glaucoma generally has a later onset, that there's by and large no pain associated with it, and the loss is by and large permanent. So, you give people enough information. It's kind of a health literacy thing to say, well, if you're in this category of people being at risk, you need to do something. And for some people people are not rational by and large. That's one thing I've learned in my 78 years on Earth. But if somebody is rational, you say you need to get your eyes checked because you're at risk. And some people are going to say, boy, I'm glad you told me, and you go do it. Then the other potential strategy would be to do something a little bit more aggressive, like a vision screening. And you can just do a pretty rough vision screening, and people pass or fail the vision screening. And then you say to the people who fail the vision screening, you need to get your eyes examined. And you don't just tell them get your eyes examined, but you follow up on that to make sure that they got their eyes examined. Because again, people don't act rationally. And then kind of the third level, and that's what we want to test in this model, is just to do eye exams, just to bring people in and just give an eye exam on site. You can do that pretty quickly to get a pretty rough estimate of what's going on. We really don't know when you think about it. We've got these kind of activities that we do, and we've number one, we don't have a standard format for doing any of these things. We kind of make it up. Not that it's bad. We just we try to make informed decisions about how to reach people. But there's not kind of a go-by that we have as a national standard that you could use for any of these things. And we don't know which is most effective. So what I would suggest to you is recognizing these kinds of patterns that we've seen. You want to go where the people are. You want to go where the high-risk populations are. So, go to federally qualified health centers, go to community-based organizations that are serving poor people, homeless people, and because wealthy people are getting their eyes examined. And so anything that targets people where they reside, getting through the health literacy. I'm doing a paper on health literacy, and health literacy among people with vision impairment is lousy. It's lousy universally in this country, but there's a dramatic difference between people without vision, with and without vision impairment, using these same data, by the way. And so how do you communicate in a way that's accessible to people who are at risk? And so there's some materials that already exist that you could use, and then some you just have to gin up, recognizing the population. For example, if you can go into Hispanic communities, is material in Spanish, number one, and is that Spanish reading level at a 6th grade level? Because you got a lot of people. So those would just be some things I would be thinking about. And I really commend you. I think we don't think enough, because this is a system. We're trying to develop a system. So if you're trying to do preventive work to avoid eye disease, and then, or just refractive error, which is most of the problem, you can have great success in terms of both of those, get people into the eye care system. And then that outreach needs to be linked to vision rehab, so that for the percent of people who have permanent vision loss, that they are not just told that nothing more can be done, that they can then get into vision rehabilitation. So we create kind of this multi-pronged system to reach people at various levels, more passive, more active, and then make sure that there's a follow-up for those people who we identify. So I think you're right on the money to be doing this kind of work. In terms of students, if they're being seen by VR, which I would presume most of them are being sponsored by VR, it's probably their eye disease is being managed in some. I just suspect. I don't know that. What I would be concerned about in terms of reaching that population is to make sure that we're doing things to assure the success of students. I went back, I did my undergraduate and graduate degree, in the early 70s. Went to college in the 60s and did my first master's in the 70s. Went back, did my second master's in the late 70s. But then I went back to do my PhD when I was in my 30s. And, it's like my brain cannot process all this information. I felt really, inadequate for the task. And so you think about a lot of students were just kind of overwhelmed by that experience. And so some of them are going to wash out and be unsuccessful. So I think one of the things I would be really interested in doing is saying, are we doing enough to support students? So anyway, I don't mean to rattle on. Thank you for the question, Amy.
Yeah, that's a really good question and helpful information, Dr. Cruz. Cindy, you had a question in the chat. Did you want to come off a mute and share that, or would you like for me to just read it from the chat?
Good morning, everyone. First of all, I want to say thank you so much for this presentation. It's not only been very enlightening, but can also become very useful for different initiatives and as you were saying, grants that may become available. But as someone who has run a Social Security Administration's Work Incentives Planning and Assistance Program for over 20 years now, I'm just curious if there's any statistics out there or any research that's been done on the potential disparity between people that are blind or low vision, visual impairments, accessing the benefits counselors and the blind work impairment as opposed to those that may not have that, be in that same category. Because as you know, Social Security is, the blind and low vision are the only ones that have their own specific, work-related impairment expenses. So I was just curious if you had any information about that or where I could find it.
So you're with Walton Options in Augusta?
Walton Options serves both Georgia and South Carolina.
Yeah, I
I'm
knew
the
that.
director of our South Carolina initiative.
Yeah, you're great. It's a great agency, by the way. I visited there, I don't know, 2 or 3 years ago, and I was super impressed with what you guys are doing. So just accolades to you. In terms of Social Security, I don't know enough to respond to that. I wish I did. I think what is curious to me, I'm going to I'm going to go from micro to macro. What's crazy to me about this country, in terms of disability policy, is that services are entirely dependent upon eligibility for services for something, and not based on need. And so what that does, I think, for the consumer is it's constantly puts them in this situation of trying to manage their eligibility for something. And those systems are generally, I don't want to overstate anything, those systems are generally not as responsive as they could be, and not as tolerant of just the human experience that they should be. And so, what I would like to see, I think, would be that our public policies would be much more supportive of it's just kind of the lip service that we give. We say we want people to be independent and have autonomy and all that, and then you put up all these barriers where they can't be independent and they can't live the lives that they want to. One example, well, I have two daughters. Just to personalize this, I have two daughters. One's 44. She's has CP. She's quadriplegic, uses power wheelchair, and so we're always managing kind of the eligibility stuff with that. And my other daughter has Down syndrome. We adopted her from Armenia, and she has Down syndrome. And we spent all half of Tuesday and maybe half of Wednesday this week waiting in a room trying to get some kind of respite care for her this summer. It was just a weird system that was not responsive to parents and children. So I guess from a big policy point of view, I think we need to think about how we can create systems of support where consumers can move more easily in and out of those systems as their needs change. And again, I think often those systems become bureaucratic and sclerotic. But that's just my opinion. I'm not answering your question directly, Cindy, but so I apologize for that.
No, thank you. I appreciate everything you have to offer. You're so insightful, and everything that you say, I'm finding quite a bit of usefulness in it, but also thought-provoking. So one of the other things that I was thinking of as you were answering was, prior to coming to Walton Options, I've been here for 24 years now. I worked for the State Department of Disabilities and Special Needs, and as the lead head and spinal cord injury service coordinator, and ran a Medicaid waiver program for attendant care and a few other things.
South Carolina or in Georgia?
Yes, sir. Sorry, in South Carolina.
Okay.
And one of the things that I did find when you were talking about eligibility, and how that can be can skew data and prevent access ways to services. I happen to agree full-heartedly. And one of the things that I was really confounded by when I was there was the idea of primary disability, and then secondary ones or whatever, as even self-reported, weren't not always getting referrals or access to the services they need. So for instance, if you were someone that had a spinal cord injury, you might say that would be your primary, disability, but it may be that you also have a visual impairment and you're not getting access because it's secondary listed. I have another gentleman that I work with that is blind, but he actually sees his primary disability as seizure disorder. So
Yeah.
I'm just curious, and it's thought provoking about some of the things that you've said as well. So thank you so much for sharing. I really appreciate it.
Well, I think what's the kind of the division that occurs often is what I tell people is, I worked 15 years providing direct services, and every idea that I've ever published on, I published like 120 papers. The genesis of those articles were from my clinical experience in Michigan. Because if you're sitting in an office, you don't see this human experience that informs the research, and so one of the things I would like to see is a stronger capacity to bridge the kind of science that's going on, kind of stuff I do, and the clinical work kind of stuff I did and that you do. And so one informs the other. And it's only by having kind of that dialogue do you refine the science. Then hopefully the refined science helps to create a lever to improve the clinical services. But we just tend to do these as separate worlds. We don't talk to each other. And there's a lot of reasons for that. I mean, scientists like to talk to scientists, and I think a lot of times scientists try to purposefully intimidate clinicians, so that they're afraid they're going to ask the wrong question, and that's not the way it should be. It really should be because this once you get just that example. I mean, I'll tell you the one. If you want to get my feathers ruffled, is if you're quadriplegic and you want to go to the bathroom or you want to get out of bed, you can't, and you need attendant care 24 hours a day or 15 hours a day. You can't make more than like $10,000-$12,000 a year to get that service. So you choose. So if you want to get out of bed, you have to choose poverty. That makes no sense at all. So who made that rule, right? Not the person. It certainly wasn't somebody who had quadriplegia. It should be, if you need to get out of bed to go to the bathroom, you can make $1 million. We don't say that to any other group. We don't say that to blind people. You can only, if you're blind, you can only make like $10,000 a year because of your blindness. But if you have that need, I mean, that's a cruel trade-off, and people are living that every day. And for some reason, we're satisfied with that. I just can't believe that's a public policy that we're satisfied with. Maybe that was good, 75 years ago, but not today. Anyway, but that's where I start moving from being the rational scientist to the irrational advocate.
Well, the two really do fit together, Dr. Cruz. And as you
Yeah.
mentioned, there's a whole other part two program on public policy and how we translate this information into public policy solutions that we can implement at a state, local, and national level. That's a whole other thing. We'll have to figure out how we can continue that conversation. But
Well, I do not I'd be mindful of the time. What I do think is just this report. If now given I know we're in this hugely turbulent time with funding, But there's enough information just in this report to make the case for a whole bunch of services. And so you can use these data. I mean, if it's another huge issue that's neglected in this country is mental health services, behavioral health services for people with disabilities. There are very few clinicians who have the skill to work with people with severe disabilities. But our findings show that those needs are great. And so you can make the case to support those services if you can find the funding mechanism to make it happen. And so you're not just speculating. You're not just saying, I think that there are behavioral health needs that need to be addressed. We have data that just show that in a very powerful way. Wrap some of that data around some of the stories that we have, and then you can if there's somebody's got money, you can make the case to grab some of it.
Absolutely. And that kind of feeds into one question that I had for you. This is related more to the South Carolina report rather than specifically to your presentation today, but there's overlap, obviously. On page 43, I'm looking at tables 5 and 6. Table 5 is health and chronic conditions, and Table 6 is health-related quality of life. Our organization, Lions Vision Services, is kind of similar to Amy's organization with Servants for Sight in that we are more on the prevention side than the
Mm-hmm.
vision rehabilitation side.
Mm-hmm.
One inference that I drew out of this report is for depression in Table 5, health and chronic conditions, depression is higher in that first year of being out of work than it is in subsequent years.
Yeah,
And then
yeah.
in health-related quality of life, 14 or more days of mental health not good, that is higher, in fact, significantly higher in out of work for less than 1 year versus out of work for 1 year or more. So from the prevention side, one of the ways we've been using that is to say, hey, if we can get to people in that first year when those symptoms are the highest and determine if it can be corrected. Again, we really value our partners at ABVI and Commission for the Blind that offer those vision rehab skills if it can't be corrected, but if it can, let's prioritize prevention in that first year to really mitigate those heightened mental health symptoms when they're
Yeah.
at their highest point. Is that a fair
I,
extrapolation from that
I
report?
mean, these are the kinds of conversations that we need to be having all over this country. Um, yeah, and I really appreciate kind of the way that your inquiry is going. I mean, I think it's spot on. So here's some suggestions. We've so in the BRFSS, we have these standard questions that have been asked, 440,000 people annually. So there's no question about the integrity of the question. It's not, you're just making it up. I would look at some of these questions, like the health-related quality of life questions and some of the others in here, and see if you could integrate those into your administrative data set. So be part of the intake. And then what you could do with that is you would have multiple measures. So if you ask the same question of your constituents, you could use it as a pre-post measure. You could say, are you depressed? I mean, would you get the right question? Are you depressed? Or like the 14 or more, or the question, how many days out of the last 30? So the response, unlike the vision question, which is a binary response, yes or no, the health-related quality of life is a 30-day response, 0 to 30. How many days out of the last? So somebody might come in and say, well, how many days out of the last 30 is your mental health not being good? And they say 30. And then you work with them and they meet other people with vision impairment and they're kind of lifted up from that experience and they're learning some things. They find things are not, not just, they're not despairing. Things are not hopeless. And then you say, well, then at exit, you say, well, out of the last 30 days, how many days was your mental health not good? And they're probably going to say, well, I don't know, maybe 7. So you go from 30 to 7. I mean, that's a measurable outcome, so you've got this measure that you can use to your funders and say, look, somebody came in at this level and they went out at this. This is the gain that our services provided. So you're not talking, so this is, and that competes. What I think is important when we're talking about these health issues is that allows us to compete in this medical environment where all the money is. And so you could say, so you're not going to, you may not cure somebody's diabetes, but you can certainly help them manage it. And so around each of these things you can do. Then what you can do is you can say, all right, here's we're going to use some data. We're going to use some questions from the BRFSS. We're going to put those into our administrative data set. Then we can tell you how our clients compare to the rest of the people in South Carolina. Are they more at risk? Are they less at risk? Or you can say, this is how our clients compare to people without vision impairment. How much more? And then you could do a kind of a pre-post. So you're trying to narrow that gap. I think that's the important thing. You're bending that curve, and that has huge value. And so I think, if you just took, say, like 10 questions that we've used in this system, in this report, and integrate those questions. They don't take long to answer 10 questions. You can answer 10 questions in 5 minutes. And so some of that might be super valuable in terms of making the case. So one thing you want to do with these data is you say, well, here's the disparity. I'm going to show you that the clients that we think we're targeting are different from everybody else. And then you have some kind of intervention. And now you can say, here's our outcome. We have improved based on this factor. We have improved the circumstances of people. Now, some of that's really long linked. So if you're an advocate and you're trying to get in the schools and making sure that children are successful in the school, you may not see the outcome for that for a decade or more. But if it's a clinical service like orientation mobility or mental health services, that sort of thing, that might be a real short turnaround. And so I think what happens from a public policy point of view is that we could describe this population and people could go away from it and say, bummer. I mean, this is terrible. Look how awful these data are. And it's so bad we can't do anything about it. However, you guys look at this and say, wow, there's opportunities in all of these things. I can do something about all of this stuff. And so if you can describe the problem, deconstruct the problem, and then say, in these areas, we can do something about it and we can measure gain, then that puts you in a very competitive environment with, for Medicaid, other kinds of funding services. And I think we've often, in our hearts, probably, the reason we get into this by and large is we want to, we're nice people wanting to do good things for people who have need. That's who we are in essence. We're not good at measuring it, but we have the tools to do so. And then the other thing, you think about other services like OTPT, they've got this, they've nailed it. They've figured out how to bill for anything. And we're not. We tend to give everything we have away. And so we just need to be a little more pragmatic in this kind of environment to measure what it is that we do. And I think we can do that. And it doesn't
I
have to be a
think
miracle.
you're spot on. We can and we have to. I like your phrase bending the curve.
Yeah.
We use the phrase turning the curve. We use
Yeah.
Mark Friedman's trying hard is not good enough, the results-based
Yeah.
accountability framework, and there's actually a coalition of us, Servants for Sight, Lions Vision Services, and ABVI that are working on a joint data project right now that is funded by a major health insurance foundation in South Carolina. And one of my next questions for you was, we're looking at how we can demonstrate return on investment and healthcare cost reductions for eye care services, both on the prevention side, things like eye exams, eyewear, eye surgeries, and that kind of thing, but also on the vision rehabilitation side as well. And just if you've got any examples of studies that you've done over the years or that you are aware of that could help us kind of build out that framework for how we can demonstrate, again, specifically to funders, how their investment in these vision rehabilitation services and
Yeah.
these preventative eye care services have a specific healthcare return on investment and cost reduction benefit to them. That's kind of what we're working towards right now. So we would love any guidance that you might have for us there.
I'm going to have to, maybe we could have another call about that. Let me think about it a little bit. But just offhand, here's what I think about. I tend to watch CNN and MSNBC a lot. And the commercials there are always targeting kind of old people who have all kinds of medical conditions. That's, one commercial after another. And you notice that what they say they're trying to treat GERD. And what they show is people they're going on picnics and they're going boating and they're with friends and they have this affiliation with other people and they're loved and all that. That's the outcome. They don't say we fixed your GERD. That's what we do. We say we're going to fix the GERD and we focus on that instead of saying, it's a quality of life thing. And we can measure. I mean, we got 4 health-related quality of life questions, that are standard that we can use. And so improving eye health is the mechanism to get to that outcome. And so the more effective you are in terms of reaching people is probably not going to reduce cost because people are getting access to care that they didn't have. But by neglecting that cost, there are costs. And
Well,
so,
and that's what we're really trying to get at
yeah,
is,
yeah,
if somebody has blindness, be it preventable or permanent, what other health costs are they incurring
yeah,
that they would not incur if
yeah,
they had either, the vision
yeah,
rehabilitation services to assist them or the preventative care to
yeah,
keep them from experiencing that. That
yeah.
that that
And
delta is what we're trying
yeah,
to document. Yeah.
I'm not offhand, I don't. Um, I suspect there's just not a whole lot of literature available. And again, I'm going to have to think about this a little bit. What
And
might
we can
be,
and we can follow up. I'd love
yeah,
to have
yeah.
another conversation with you.
But I think it's a great idea.
We're kind of finding the same thing, by the way. So that's
Yeah,
I was hoping that you would have
yeah,
something in your back pocket, some stone that we had not
yeah.
turned over yet.
But what I think is what happens is it's a proxy measure, So all of these medicines that they're trying to market, they're not marketing what the clinical mechanism that's happening with with a particular tablet. The outcome is always in this kind of this social integration thing. If you have all these diseases, you're going to have friends and you're going to be happy and you're going to be participating in social events in the community. And that's how they represent the outcome. And so we need to capture a more macro level way of measuring gain. And so one of those might be things like health related quality of life. But I think, again, what I think is important and I mean, I continue to learn. It's just we're on a trajectory, and left alone, it's only going to get worse.
Yeah.
And so it's how do you figure out what that intervention is to begin to bend that? And it doesn't have that bend does not have to be dramatic. It doesn't have to go from somebody, you know, and I think that tends to be the way Americans, I mean, in a way, we want to solve the whole problem. And and what we're doing is we're modifying the direction of that. And so capturing, I think, some of that is important. But let me think. It's a great idea, and I'm happy to help think through some of those things.
Yeah, let's keep in touch on that. I
Okay,
know we're way
absolutely.
over time, but I have one final question that I have to ask, just related to the big data project as a whole. You mentioned the comparison between different states, which I love.
Mhm.
That was one of my questions. I'm always wondering, how do we compare to our neighbors in North Carolina and in Georgia? But then I also, from a public health standpoint, I've seen things like the county health rankings from the Robert Wood Johnson Foundation, and looking at national health trends at the county level paints some interesting pictures. I know that there's a national report that looks at the state level trends and nationwide numbers. Is there any plan to break that national report down? I guess, frankly, kind of like those county roadmaps, where you could demonstrate a county map of the whole nation to look at those eye care trends at a more macro level, and regional too, to see, like, are there trends in the Southeast that differ from trends in the Northwest or in the Pacific? So just wondering if there's any plans for further national analysis. And then, as you pointed, Massachusetts seems to be doing some things well, and struggling in other areas.
Yeah.
Is there any plan to identify maybe some policies or some best practices in those states that have those outlier positive numbers to say, hey, clearly something's working here. Either it's a policy or it's a program or it's an organization or entity or something. So are there any plans to explore some of those national best practices as a result of the data?
Two things I'm going to say, and I'm going to let Lee answer the question. Number one is I'm 78 years old, and I just submitted this grant with Ohio State to NEI. And if we get funded, that'll get me to age 84, which might get me to retirement. If not, so that's one. Number two is I think all of that work needs to be done is finding an appropriate funding source. And with that, I'll let Lee
Yeah.
comment.
Oh, there's so much more research we need to do, so many other data we want to collect. And yes, it all comes down to money, unfortunately. We are talking about a couple of additional projects for the next few years. If we can find funding sources for them, we will move forward. Um, and if not, we may still put the ideas out there. I would love to do a Vulcan mind meld with Dr. Cruz so that we can continue all the ideas and projects he has over the next 20 years, which, by the way, I will have retired by then too. But let's capture some of these things, and as a national association and our regional partners like you all, what can we do? This is important. Let's just not talk about it. Let's really try to focus and get a little more of this work accomplished in the next decade. What do you think?
I love it. Let's roll up our sleeves and do it.
Right. Great discussion today. So many good.
Yes, thank you all so much. I appreciate everyone hanging in to the very end here. Dr. Cruz, thank you for your time and
My
expertise.
pleasure.
I can tell you this was a very highly anticipated program, and I think we're all leaving with very helpful insights that will strengthen us in our work today and in the years to come. So we look forward to keeping in touch. Palmetto Vision Alliance will reconvene later this year to continue our work. And thank you all for joining us again for today's program. Again, thank you to VisionServe Alliance for supporting this at the national level, and Dr. Cruz for your expertise. Thank you to our South Carolina funding partners, the Commission for the Blind, ABVI, and Lions Vision Services. Hope everyone has a wonderful day. Thank you.
Bye-bye.
The